So let's take the next question then. So based on this image, which type of injury is shown according to the Bismuth Strasberg classification? Okay. So the options are type A, type B, type C and type D. Okay. So there is an image that has been given. So before going into this question, I would like to have a quick recapitulate of the hepatobiliary anatomy. Okay. So your right hepatic duct and left hepatic duct forms common hepatic duct, right? So the common hepatic duct basically forms by the joining of the right and left hepatic duct. And the cystic duct also join with a common hepatic duct to form the CBD. So this CBD basically opens into the second part of the duodenum, right? And obviously apart from the CBD, there is a main pancreatic duct that basically joins with it and form a common channel they open at the level of the ampoule of water, right? Now, uh, so there is a gallbladder is there. So from this gallbladder, there is origin of the cystic duct, right? Now this gallbladder basically attached with the liver, right? So this gallbladder basically attached with the liver at the level of the gallbladder fossa or the GB fossa. Okay. So sometimes there is a aberrant or abnormal subhepatic duct is there, which is known as the duct of Luschka, that originated from or that basically drains the area around the gallbladder fossa of the liver and directly drain into the gallbladder like this. Okay. So this is basically your duct of Luschka. Duct of Luschka. Okay. Now there is another aberrant anatomy that is basically there or present, which is the aberrant right hepatic arch, right hepatic duct. So this aberrant right hepatic duct is basically draining the posterior segment of the right side of the liver, that is specifically segment 5 and 6 and all. So they basically drain this portion, as the name suggests, it's aberrant. So they are basically abnormally located and they basically drain directly into the CVD. Okay. So that's why they're aberrant in nature and aberrant in location, that basically makes them much more susceptible to get injured. Okay. So this is the basic idea of the anatomy. Now let's go to the question. So in this question, so you can easily able to appreciate that there is a leak, right? So there is a leak from this two area. So let us presume from the knowledge of the anatomy. So this is the cystic duct, right? So this is the cystic duct and this is somewhere from the duct of Luschka. Okay, duct of Luschka, right? So there is a leak from the duct of Luschka and the cystic duct. Okay, now let's try to understand regarding Bismuth and Strasberg classification. So regarding the Strasberg classification of the bile duct injury, we have the minor injury and the major injury. So your minor injuries are A to D. Type A to type D is basically the minor injury and there is a major injury which is the type E injury. So this type E injury basically is again subclassified by the Bismuth. So that's why it's known as a Strasberg and Bismuth classification. So in this classification, it is a type A. So the type A basically suggestive of that there is a bile leak. So bile leak from either from the cystic duct or it could be from the duct of Luschka, right? And there is a normal CBD continuity is there. So obviously you can see in this image that this is the cystic duct from where there is a leakage and this is the duct of Luschka. Okay. And the same question has been given, uh, uh, the same image has been given in the question as well. So this is going to be your answer. So your answer is the type A injury, this question. Now let's try to see the other option as well. Now the type B, right? So your type B is basically there is a occlusion. Okay. So your type B and type C is more or less similar, like the injury, the level of the injury is somewhere the similar, but how does it present, that is going to be the difference. So in case of type B, there is a occlusion of the aberrant right hepatic duct. So I have already mentioned you regarding the aberrant right hepatic duct. They are basically aberrant in nature, directly draining into the CBD, locating abnormally, right? So this aberrant right hepatic duct usually occluded, but in the same thing in case of type C, it's not occluded. So there is a leakage from the aberrant right hepatic duct. You can easily able to appreciate that, right? So this is going to be the main difference between the type B and type C. In case of type B, it's occluded, and type C, it's a leak. Okay. Now your type D, where we can able to appreciate that there is a lateral injury to the CBD. So there is a lateral tear or the partial tear in the wall of the CBD. So it's not only in the CBD, it can be also happen in the common hepatic duct as well. So as a result of that, there is a bile leak from there. Okay, but the other rest of the biliary hepatobiliary anatomy, they will eventually maintain the continuity from here. Now your major injuries, like these are your type E. So this type E is basically associated with a complete transection mostly. Now you have to understand the adaptation of the bismuth. So your bismuth adaptation basically classified into another subclassification. So we have the type E1, where the transection, so there is a transection in the hepatobiliary tree. This transection is basically located away or 2 centimeter away from the confluence, that is basically your E1. So that transection of the stricture basically located more than 2 centimeter away from the confluence. But the same thing, if this transection is basically located within 2 centimeter of the confluence, it's basically your E2. You can easily able to appreciate that. So there is a transection is there, but when it is more than 2 centimeter away, it's a E1. Within 2 centimeter, E2. Now your E3, right? So your E3 is basically the stricture at the level of the confluence. But as a result of this injury, still there is a communication between the right and left hepatic duct. Okay, so the injury is at the level of the confluence, but mm, your right hepatic duct and the left hepatic duct still communicating with each other. But when the injury is somewhere in the confluence, but these two, right and left hepatic duct, does not communicate with each other. So in that case, it is going to be your E4, right? It is going to be your E4. And then obviously your E5 comes when there is a complete transection of the common hepatic duct of the common bile duct, and as well as there is a clipped and transected aberrant right hepatic artery as well. So this one is basically the addition, right? This one is basically the addition. Now let's try to understand the management of the bile duct injury. Why it is important, that also you need to understand, because your laparoscopic cholecystectomy is basically one of the most commonly performed surgeries in worldwide as well. So your bile duct injury is the one of the most fearsome and the most important complication as well. So that's why we need to understand how to diagnose and how do they basically present. Okay, so your bile duct injury is the one of the most important topic from the exam perspective. So there is a multiple question has been asked in the recent examination. Please try to be attentive while I try to get the concept clear for you. So first of all, let's try to understand. We are going to divide this whole scenario into 3 segments. So first of all, the surgeon able to diagnose that there is a bile injury during the time of OT, okay, or during the time of the operation itself. So it's an intraoperative diagnosis. Sometimes it may be just immediate post-operative scenario, right? So like in case of post-operative day 1 or day 2, in that time during the round, the surgeon able to encounter that yes, there is a evidence of the post-operative bile leak, right? And or the post-operative bile duct injury, or sometimes there is also chances that the surgeon able to diagnose the same scenario even after the discharge, like the patient has been discharged and the patient came up with some symptoms, and the surgeon able to diagnose a scenario, it could be mostly after 72 hours. So these are the one with a delayed diagnosis, okay, delayed presentation. Let's try to understand regarding the intraoperative diagnosis first. So here during the intraoperative diagnosis, while the surgeon able to encounter that there is some kind of problem is there in the bile duct, so he or she need to understand whether there is any tissue loss has been there or not, okay, because this is the one that is going to direct us towards regarding how to approach such scenario. So let's suppose there is a no tissue loss, then how should we uh, go in that case? So obviously there the main thing is that mostly this kind of injury happens due to electrocautery burn. So as we know, like the diathermy or the monopolar cautery, they are basically associated with a much more lateral spread. So that's why they are associated with a much more chances of this kind of burn related injury, okay, or sometimes there is a partial cut with a sharp instrument during the dissection that can also happen. So this was regarding the no tissue loss. Now, when you are able to encounter that there is a no tissue loss, then you have to understand the circumference, like the injury that has been located, whether it is the less than 50% of the circumference is involved or the more than 50% circumference is involved. So, in case of less than 50%, obviously it's a pretty much easy to solve or pretty much easy to repair, because we can simply go for primary repair. So, this primary repair is supposed to be done with a fine absorbable suture. Now it's a depend upon whether obviously is the number one is the surgeon's choice in some cases, as well as like the diameter of the injury is also the main determining factor regarding whether the surgeon is going for this repair with a continuous fashion or the interrupted manner, okay. So these are the management aspect for less than 50% circumference involved. But if there is more than 50% circumference involved, then what you do need to go? So your aim is to just get the idea regarding whether there is a good tissue is basically there for the repair or not. If it is there, then obviously it's a good thing. But if it is not there, so then in that case you would like to go for the Roux-en-Y hepaticojejunostomy. Okay, so your biliary anastomosis is going to be the end statement here. But obviously, if there is a good tissue is there for the for our repair, so in that case we are going to put some T tube there. Okay, so this we are going to put some T tube. But one thing that you need to understand, let's suppose this is the bile duct, right? And obviously there is some injuries there. So we are not going to introduce the T tube from this side. No, it's a big no. Okay, we are not going to introduce the T tube from the injured area. So instead of that, what we are going to do, we are going to introduce the T tube either somewhere proximally or distally from a fresh area. Okay, then after, let's suppose we are going to introduce the T tube from here. Okay, and after introduction of the T tube, some other choledochotomy, then we are try to repair that over the T tube. Okay, so this is how it is supposed to be done. Okay, now in case you are dealing with a patient with intraoperative diagnosis, obviously there is a no tissue loss has been already taken care of. But if there is a tissue loss, then what you supposed to do? So in such cases, there is a mostly the scenario is that some clip has been applied over CBD, or there is a some kind of transection that happened uh, at the level of the CBD or the common hepatic duct. So in that case, your main determining factor would be whether the surgeon is pretty much well experienced to deal such scenario or not. If he is, if he or she is, basically in that case, it's a pretty much simple. The surgeon need to go for the refashioning of the edge, refashioning of the both edge, proximal and the distal edge, and obviously put some stent in between in that case. And the main operation is going to be the Roux-en-Y hepaticojejunostomy. That's it. Okay, Roux-en-Y hepaticojejunostomy is supposed to be done. Obviously, the with a proximal end, and the distal end is supposed to be closed. Now, in case the surgeon is not experienced, so first thing is that the surgeon is supposed to put some drain inside. Okay, just to make it a controlled fistula, and then he or she is supposed to refer the patient to a high volume center where the lots of the hepatobiliary cases are basically done. Okay. Now, regarding your immediate post-operative period, so first thing we need to take care of that whether the patient already developed sepsis or not. If it is yes, your main idea is going to be the control of the sepsis. So, in that case, you have to put the patient on the ICU. Now, your next aim would be localize the area of injury. So, in that case, you have the ERCP, you have the cholangiogram, and also you can take the help of the CT or the contrast and CT, which is not going to be very much important to recognize the area of the injury, but rather the associated inflammation of the any other vascular injury has been done or not. Okay, so in case uh, you have not already put any drain inside the abdomen, so obviously there is a formation of the bilioma. Okay, so there is a lot of collection of the bile inside, so we need to drain that fast. Okay, so for draining that, or the drainage of the bilioma, obviously you have your ultrasound guided or sometimes the percutaneous a drainage system or a drainage procedure is there. So this drainage is very much essential just to control the sepsis as well in such cases. So following that, you can also go for the ERCP guided or the PTC guided decompression of the biliary duct in such cases with a complete occlusion as well. So that is also going to help in such cases. So just to get the overview regarding how to manage such cases, your type A, type C and the type D. So these are the three things or the three scenario where simple ERCP and stent with a ERCP guided stent placement and you do the sphincterotomy would be helpful. Nothing else is basically required to manage such patient. But obviously, in case of the major bile duct injury, in that case, we need to go for the biliary anastomosis like the hepaticojejunostomy, Roux-en-Y hepaticojejunostomy. But that is supposed to be done on the delayed basis. Like we have to wait for 12 weeks minimum. So in between that period, we can easily go for the bilateral PTBD to decompress the biliary system. Now, the patient may present to you with a immediate postoperative period and there is no evidence of sepsis. Obviously, it's a good thing for you. So in that case, you have to assess whether there is any vascular injury has been there associated with the biliary injury or not. So for that case, you have to go for the MRI. Okay, so your MRI with the contrast or the MSCP would be pretty much helpful. If it is yes or no, so that is how is going to direct you which way you are supposed to go. So if there is a no hepatobiliary injury, sorry, if there is no vascular injury has been there associated with the biliary injury, it's good. So obviously you can go for the repair. But at all, if there is any vascular injury is there with a biliary injury, you have to wait for some time. Why? Because the chances is there that you need to go for the hepatic resection. Okay, so for that case, your delayed repair is supposed to be warranted. Now, obviously, you are able to get the cholangiography report from the ERCP and the uh, cholangiography, and depending upon that, there is a few scenario that may come up. Like one is the cystic duct stump leak, which is the most common scenario. Apart from that, there is a lateral or the partial bile duct injury or tear would be there, or sometimes the complete CVD transaction also can be seen. Now, your cystic duct stump leak, that is a pretty much common. Why it is happen? Sometimes the patient may present to you with a large and stout cystic duct. So in that case, even a large clip is not able to accommodate the entire cystic duct. Okay, so in that cases, this kind of scenario may happen, or sometimes there is a uh, uh, you are dealing with a lots of inflammation in the surroundings structure. So in that case, the friable tissue from the inflammation and necrosis may result from this as well. So let's suppose there is a distal CBD stricture, right? Or there is a distal CBD stone. So as a result of that, obviously the proximal area, there is a biliary hypertension would be there. So this pressure eventually is basically transmitted at the cystic duct as well, or the cystic duct stump as well. So as a result of that, obviously there is a chances of the cystic duct stump leak. Now, what are the ways that we had to prevent such scenario? So our fast way to prevent such scenario is the suture closure. We can like introduce the suture inside the abdomen, and we can put the suture laparoscopically. Okay, or there is a availability of the pre-tied suture which can be applied over the cystic duct. That is also there. But the problem with this two technique is that where the clip is basically easy to apply during the laparoscopic procedure, but this suture closure or the pre-tied loop suture, that is basically is a technically challenging. Okay, so that's why the issue is there. Now the another option that has been there, that is the laparoscopic stapler approach. So this laparoscopic stapler is always there, but it is pretty much costly in that case. Okay, so if there is any of this either risk factor is there, it is always better to put some drain inside while doing the laparoscopic cholecystectomy, because if there is any chances of the biliary leak, that will be basically not forming the bilioma, instead it will be a controlled biliary fistula. Okay, so the sepsis will not be there in that case. Obviously it will be easy to tackle in that case, right? Now let's try to understand what is the management of the cystic duct stump leak. So the cystic duct stump leak is eventually treated with ERCP. So with the ERCP, first of all, we try to go for the sphincterotomy. Okay, so a sphincterotomy is done, followed by we can sometime or most of the time we have to place the ERCP stent. Okay, so as a result of that stump, obviously the whole biliary flow would be maintained. And obviously you can also put some drain, it's a percutaneous drain to drain the biliary uh, content in that case from the HRPM. And obviously after a few days, when the bile drain bile output would be decreased, then obviously we can reassess the scenario with a ERCP after 4 weeks. If then everything would be fine, reassurance of the leak is there, so we can easily remove the stent as well. Okay, so this is how you are supposed to deal with this. Now your lateral or the partial bile duct injury or the partial transection. So there is a two kind of scenario, like this partial laceration is maybe due to electrocautery or the sharp injury is there. So if it is there, obviously it's a good thing. It is the management of such cases is similar to that of the cystic duct stump leak. But if it is not like that, like the electrocautery or the partial laceration is not seen in that case, obviously it is supposed to be treated as a complete CBD transection. Okay. Now, how to manage this complete CBD transection? So for that case, obviously always try to remember your way to go is the Roux-en-Y hepaticojejunostomy, and that is supposed to done after 4 to 6 weeks in a minimum duration. Always before going into the Roux-en-Y hepaticojejunostomy, you have to ensure that the adequate vascular supply and the a biliary duct is supposed to be there, because otherwise there is a chances of stricture formation increases. Okay, also you have to make sure that near the hepatic bifurcation all the draining bile ducts are supposed to be there, and you have to make the anastomosis with that as well. Okay, otherwise it will be associated with the postoperative leak. Sometimes few surgeons basically prefer percutaneous PTC placement. So this PTC placement in situ, and they basically try to repair and make the anastomosis over this thing, this PTC. So that will eventually decreases the leakage chance or the stricture chance as well. So this is the another adaptation which can be done. Okay. So this is how you are supposed to manage uh, complete CVD transaction. Now your management in case of delayed bile duct injury. So most of the cases this delayed means how much delay. So it is supposed to be 72 hours delay from the time of injury. Now most of the time the patient will come to you, either there is some kind of occlusion. So as a result of that there is obstructive jaundice, followed by there is a cholangitis, the possibility is there, or there is a bilioma or the biliary a collection within the peritoneum would be there. So as a result of that, the patient will eventually comes to you with a fever, there is an infection, there is a right upper quadrant pain, jaundice or raised liver enzymes. These are pretty much seen in that case. So obviously in that case you have to first of all go for the your first investigation. In that case obviously going to be the USG ultrasound. So in the ultrasound you are may be able to get the idea regarding the intrahepatic biliary radicals dilatation. Sometimes there is a perihepatic collection that can also be seen, or the bilioma abscess. These are the typical findings you can easily able to get in the USG. Now the basic idea regarding the delayed identified bile duct injury is that you have to wait for reconstruction. You have to wait and you have to resuscitate the patient, prepare for the OT or the operation. So during that phase, why it is done so? Because your acute inflammatory stage or acute periportal inflammation, in that case it is very much difficult to find the two ends of the bile duct. This is the number one, and obviously it's very difficult to repair that tissue as well, because as a result of the inflammation the tissues are basically much more friable than the normal. So this is going to be the issue. Now obviously as a result of injury during the acute inflammatory stage, there is a retraction of the bile duct inside the hilum of the liver. So that's why they're also difficult to find the age as well. So as a result of that, this whole scenario will make the reconstruction difficult, and the prognosis is much more difficult, much more bad as well. So your management of the delayed BDI here, obviously you have to resuscitate the patient, resuscitate, and resuscitate. But your primary goal would be always take care of the sepsis. Sepsis control is the one of the most important thing. So obviously to control the sepsis, you have to drain the bile, you have to apply a broad spectrum antibiotics, you have to control the inflammation. Okay, so these are the three important pillars. Apart from that, in some cases there is occlusion. So as a result of occlusion, there is a ductal hypertension. So this ductal hypertension eventually associated with the jaundice, obstructive jaundice, and that obstructive jaundice sometimes may complicate or being the cause of the sepsis is the cholangitis. So in that case you have to decompress the whole biliary duct. So your option that has been available, either you can go through ERCP, which is mostly not available or mostly not feasible in such scenario, but you can also do the same thing with a PTBD as well. Okay, so these are the options that you have to control the sepsis. Now your second goal is always to delineate the biliary anatomy. Okay, so to delineate the biliary anatomy, you have the MRCP in your one hand just to get the biliary anatomical picture, and your CT scan with a contrast, which is pretty much helpful to get the idea regarding the vascular injury or the vascular anatomy. So you are easily able to get the intrahepatic anatomy, your biliary bifurcation status, whether the confluence is intact or not, or the bile duct continuity and the location of injury. These are the things these are the informations that is basically obtained from the MRCP and the CT scan. Okay, so this is how you are supposed to manage a case of the delayed bile duct injury. And obviously after delayed means obviously there is a 4 to 6 weeks you have to wait. After that you can easily repair the case according to the cholangiography reading. So that cholangiography reading I have already discussed, like the cystic duct, it's a partial a bile duct injury or the complete one, right? Okay. So this is it regarding the bile duct injury. Now let's come back to the question. So obviously we have already discussed. So your in this image there is a bile leakage from the cystic duct and the Dr. Plushka, right? So as a result of that, it is going to be a part of type A. Okay, so this type A is going to be the answer here.